You see them everywhere in a hospital, right? That classic IV bag, the cleared tube, the whole setup. It's probably one of the most common medical tools out there. But what's really going on with it? Well, in this explainer, we're going to pull back the curtain on the simple hospital drip.
I mean, have you ever actually stopped to think about it? What's the science behind that bag of fluid in that little tube? How does it work? And why is it so important? Let's break it all down.
All right, first things first. The easiest way to think about an IV is to picture it as your body's own personal express lane. It's a direct highway for getting exactly what you need right where it needs to go with zero traffic.
So what is it, technically? A peripheral IV is basically a super thin, flexible plastic tube. You might hear it called a cannula. It's gently inserted into a vein, usually in your hand or your arm, and just like that, you've created a direct pipeline into the bloodstream.
And that little pipeline? It's used for some seriously critical stuff. We're talking about giving medications, pushing fluids when someone's dehydrated, doing blood transfusions, or even delivering the special dye needed for things like CT scans. And in emergency, it's an absolute lifeline.
Now, the real magic of this express lane is something called 100% bioavailability. See, when you swallow a pill, it has to go through your stomach, your gut, your liver, and you lose some of the medication along the way. But with an IV? Nope. It bypasses all of that. Every single drop goes straight into your circulation, which means the effect is almost instant. And in an emergency, that speed can literally save a life.
So, the big question, what is actually in that IV bag hanging by the bed? Well, the fluids flowing through that express lane pretty much fall into two main camps: crystalloids and colloids.
And the difference between them all comes down to size. Particle size, that is. Crystalloids are made of tiny particles that can easily leak out of your blood vessels and into the surrounding tissues. Think of them like a soaker hose watering the whole garden bed. Colloids, on the other hand, have big, bulky particles that are too large to escape. They stay locked inside your veins, acting more like a regular garden hose to quickly boost the pressure right inside the vessel.
So the most common crystalloids you're going to see are things like normal saline, which is basically just purified salt water that's great for restoring electrolytes, or maybe Ringer's lactate. You'll also see D5W, which is just dextrose, a type of sugar in water, perfect for giving a little boost of energy. These are the real workhorses for day-to-day hydration.
Colloids, though, these are for more serious situations. Things like albumin or geliffusion are what we call volume expanders. Because those big particles keep fluid trapped inside the blood vessels, they are fantastic at rapidly jacking up your blood volume, say after a major injury or in cases of severe dehydration.
Okay, so IVs are amazing, but it's not always a perfectly smooth ride. Now that we know what goes into them, we need to talk about the most common complication that can happen: a condition called phlebitis. Phlebitis, in a nutshell, is just inflammation of a vein. It's the #1 thing that doctors and nurses are constantly on the lookout for whenever a patient has an IV line in. So what actually triggers this inflammation? Well, you can pretty much boil it down to 3 main culprits: mechanical issues, chemical issues, and of course, infective issues.
First up, mechanical causes. This is all about the physics of the IV itself. If the cannula is just a bit too big for that specific vein, or if it's placed too close to a joint, like your wrist or elbow that's always moving, it can physically rub and irritate the vein wall. Same thing if it's not taped down securely and it's wiggling around.
Then you have chemical causes. In this case, it's the actual stuff being infused that's the problem. Some medications are just naturally irritating to veins, or it could be the specific pH level or the concentration of the drug that's just not agreeing with the vein, causing it to get inflamed.
And the third cause, which is a really big deal, is infection. This one's pretty straightforward. It's all about contamination. It's exactly why those basic steps, like vigorous hand washing, properly sterilizing the skin before insertion, and using totally sterile equipment, are just non-negotiable. Knowing the risks is one thing. But how do healthcare pros actually stay on top of it? Well, this is where it gets pretty clever. They use a systematic scoring tool to track phlebitis. This right here is the Visual Infusion Phlebitis Score, or VIP score for short. Nurses use this chart on every single shift to check an IV site. It's a simple, standardized scale that goes from 0, which means the site looks perfectly healthy, all the way up to 5, which signals a serious problem. They're looking for key signs like pain, redness, and swelling.
Now, out of all those numbers on the chart, the one that really matters is 2. 2 is the tipping point. A score of 0 or 1 just means keep an eye on it. But the moment a site scores a 2, which means the patient feels pain and you can see redness or swelling, that's it. The protocol is crystal clear. That IV has to come out and be moved to a brand new spot.
So, this all leads to the obvious question. How do we stop these problems from even starting? Well, it all comes down to a few simple proactive steps to keep that IV site safe and sound.
It's really a constant loop of care. First, you flush the line regularly with a bit of saline just to make sure it's open and nothing's blocking it. Next, you check the site every single shift, using that VIP score we just talked about. And finally, you document absolutely everything. The date it went in, every single check, and the data came out.
And all of this leads to one of the most fundamental rules of IV safety. To reduce all those risks, the mechanical, the chemical, and the infectious ones, an IV is not meant to stay in the same vein forever. The standard guideline is that if a patient still needs IV access, that cannula needs to be taken out and moved to a new site every 72 hours. 3 days and it's time for a change of scenery.
So there you have it, the science behind the simple hospital drip, from the fluids that go in it to the amazing systems that keep it safe. And that just leaves me with one question for you. What's another common medical procedure you think we should demystify next?